So thank you very much, Professor Mashtei, for this very kind introduction, and good afternoon, everybody. This is a real pleasure for me to be here, to be part of this V3 clinical solution session. And yeah, I really would like to thank the MIS team for giving me this opportunity. So basically today what I would like to talk about is about really routine dentistry. Because I think probably one of the most common indication for implant placement is single tooth replacement in the posterior region. But what we also facing quite often in our practice is this type of implant complications. I mean, peri-implantitis, peri-implant disease, loss of osseointegration, and this is really complicated to solve. So the goal of my lecture is not really to talk about how to solve peri-implantitis. I think other speakers talk about that. But maybe it's important to realize, to talk a little bit about the epidemiology. It's 1 patient out of 5, according to recent research, that is affected by this peri-implant disease. And this is the case for 1 implant out of 10. And even worse, if we're looking at mucositis, which is in a way the first step before further development of such disease, it's almost 1 out of 2, 43%. So last year, the EFP, the European Federation of Periodontology, organized a workshop on prevention of periodontal disease and peri-implant disease. And I had the opportunity to be in the group of prevention of peri-implant disease. And we came out after the workshop with several recommendations. And within these, I actually recommend you to read the final paper. But what I would like to focus on in this lecture is about the recommendation related to the peri-implant soft tissues, and also how prosthodontic design of the implant component and their manipulation can sometimes be harmful for the long-term implant success. So basically my goal today, it's not to talk about osseointegration. It's been 50 years or more that we're talking about that, but I would like to rather focus on what I would call the mucointegration. The integration of the peri-implant soft tissues. This is actually a very, very important aspect on the implant restoration, because it's really the sealing. This is the barrier between the bone that is sterile, and the oral cavity that is full of bacteria. And actually, I was happy to see the wonderful presentation, by the way, of Victor Clavijo that gave the prosthodontic perspective of these implant components. And what I would like to do for the next 25 minutes is to discuss the biological, the periodontal aspect of such implant components. So you must know that this interface, this what I call mucointegration, is where you have the installation of the biological width, that is an adhesion of epithelial cells. This is the junctional epithelium, and in the more apical part, just above the bone, we have a connective adhesion. And this dimension is about 3 to 4 millimeter, and we have 2 millimeters of junctional epithelium, and the rest is usually connective tissue. So I would like to raise a first question. It's about the material. We've already talked about material, and I would like actually to come back now to the osseointegration. We know that to get an osseointegration, we cannot use gold, for example. Gold does not allow osseointegration, while titanium does. And now I would like to discuss with you what material allow the mucointegration, what material allow the adhesion of these epithelial and connective tissues. So I think this is quite crystal clear into the literature that titanium and zirconia are biocompatible materials. You can see here images from retrieved abutments or retrieved healing abutments after a few months. And when we look at them in the electron microscope, we can see that we have epithelial cells sticking really to the material. So, and we have, I would say, emerging evidence that the PEEK also allows the adhesion and is biocompatible for implant suprastructure. But when we use these components, usually they come back from the lab. And in the lab, they are subjected to many manipulation, many products, and is the component still biocompatible when it comes back from the lab? And looking at an abutment like this, and even when they come from the company, from all of the company, they're usually not sterile. And when you look at them, you can see these stainings, and there are organic residues, usually from fat products. And personally, I don't feel very confident to put them in the mouth like that. So I think every group has this little recipe to clean them, and I would like to share with you how we're doing in our university in Liège, and this was part of the master thesis of a prosthodontic student, Noémie Lardot, and she checked the abutment before and after a very simple treatment that can be used in the practice using the little ultrasonic device. And the first solution is for 2 minutes in a soapy solution, in a detergent, and then sterile water, and then alcohol. Of course, the alcohol is not good for the cells, because it has a kind of fixation effect. It has to be dried, really dried. And then when we observe the same abutment after this treatment in the electron microscope, it looks at least cleaner. And personally, I feel more comfortable to put an abutment like this in the mouths of the patients. So if we go to the elementary analysis of these abutments, we can also see that before and after, all the carbon are gone. So now coming back to the other materials, because many other materials are used in daily practice, like resin, whether it is PMMA or a composite, lithium disilicate, chrome cobalt. We don't really know. We don't have evidence that they allow the adhesion or the adhesion of the soft tissue cells. And we were also a little bit concerned about the connection of the thigh base, because, you know, we have a glued connection really deep under the gingiva. And this is why we started a research together with MIS to see if these thigh base components are good for mucointegration. And we compared titanium, zirconia on thigh base, and then PMMA as a negative control. You see here the picture of my colleague Geoffrey Leclou. We're doing lots of research together, and we placed the C1 implant, in this case, 3 months after extraction of the teeth of the mini pigs. It's a mini pig model here. It's really important to mention, because we're going to rediscuss this mini pig model. And the implants were placed at the bone level. The abutments were put in place, and then suture. And after 3 months, we did non-decalcified histology. So here, this is the large magnification images. We see that I'm not going to go into all the numbers. I just want to give you the conclusion of our study. In terms of bone loss, there were not statistically difference between the groups. And if we look a bit from closer at the mucointegration, we see that, of course, titanium and zirconia allowed, of course, the integration. We have a long junctional epithelium all the way with a little sulcus. Same for the thigh-base group. And for the PMMA, we were really surprised, actually, even though you see that in the more coronal part, it's a little bit not very good. We also had an adhesion of the soft tissue. So it was really surprising, because it makes sense that it's not biocompatible. You have a lot of monomer release. And we actually conclude from the study that probably the model was not such a good model. We also saw on this model, and it's controversial with what we found in dogs or in human, is that these epithelial cells, they go all the way to the bone. It's like there is no connective attachment. So I definitely think that we have to be very cautious with the result of this study, and we are actually working now on the development of a model on human. I think we really do need to test that on human to make sure of the biocompatibility of these materials. So now, when we have a biocompatible material, we also have to understand that this mucointegration around an implant is very different from what we find around a natural tooth. First of all, the vascularization is very different, and it's less good around an implant. And the collagen fibers around an implant are parallel and not attached to the abutment, but rather it's just a very fragile, very soft adhesion. While around the natural tooth, it's very strong. And for example, where we probe around an implant, we are actually disturbing this adhesion, this peri-implant integration of the gingiva. So I would like now to point out that if we have this good integration of the soft tissue, this can easily be disrupted by cement. And that is also something we are seeing very often in the practice. And yes, I mean, I think because of that, many practitioners now do not want to work with cement retain restoration. And it's true that I also not very happy when I have to do a surgery on my implants to remove the cement. That's really bad. It's not that I don't like cemented restoration. Actually, I very much like one abutment, one-time solution in the aesthetic zone. But of course, in situations like this, we have to have a proper design of the abutment with a limit that is not deep subgingival. It can be just like 0.5 millimeter. And we also have to develop some prosthodontic technique to not disturb the integration of the soft tissues. So this is why also many of us, I think, want to go for a screw retain restoration. And this is here, for example, a case we've done in the aesthetic zone together with my colleague, prosthodontic colleague, Amélie Majot. But, and this is, I think, a very important slide that I like a lot, we have to be aware that when we do screw retain restoration at the bone level, on bone level implant, when we disconnect this abutment, as this one you see here, actually this is a provisional crown that I screwed for several months because the patient was undergoing an orthodontic treatment. And after a year, I removed this provisional crown, and you see that I took care to put a titanium biocompatible materials during this transitional phase. And the white layer you see on the abutment, this is not bacteria. This is actually very nice accumulation, a very nice epithelial adhesion. And by removing the abutment, actually we have created a rupture of the soft tissues. The epithelial cells, they came together with the abutment because they were actually sticking well to these biocompatible materials. And you see some bleeding inside. It's not because there is inflammation, it's because it's the connective tissue and there is blood vessel into the connective tissues. So we have to be aware that when we are doing a repeated disconnection of abutment and the bone level, we have a reapicalization of the biological width, and this leads to a bone loss, at least when the abutment, that is replaced is not cleaned, or we can also take care when we remove it to put it in saline, that the cells that are sticking to them are not dying. So now how then to optimize what to do if cement restoration is not good, if screw-retained restoration are not good, how to optimize what to do with this mucointegration. And as a first recommendation, and we can of course have the discussion on the importance of enhancing soft tissues, the quality and the quantity of soft tissues around implant. It's true that the evidence that we have less bone loss is not strong, but there is evidence that there is more plaque and more inflammation with a dimension of keratinized tissue that is below 2 millimeters. So definitely, even for the posterior region, I do recommend when you just have a little thin quantity of keratinized tissue to augment it prior to your surgery. This can be really easily done with epithelial connective tissue graft, like here, but this can also be done in the posterior. And of course, we can observe afterwards a very nice peri-implant soft tissue. And I think this is probably better for long-term success of the implants. Similar thing for the anterior zone. There we would rather use a connective tissue graft. So now, second recommendation, to optimize, to improve the peri-implant soft tissues, is to use a platform switching implant with a concave or a tulip-shaped abutment. Because you see on these images that the connective tissue can really get organized. The collagen fibers are in a circular organization, and this gives like a vertical stability. So this is what I would call the O-ring stability. And on the other side, by using such implant prosthodontic design, there is a thickening of the soft tissues under the shape of the abutment. Finally, it is true that for the posterior region, I would actually recommend screw-retained restoration, but I would not recommend it at the bone level. I would recommend to use an intermediate component, like a multi-unit, and you see it nicely on the case from Erik van Doren, or for single tooth on a single unit. But single units are not yet, I think, available on the MIS portfolio, but I think it is for soon. Or the other option is to do the screw-retained restoration on a tissue-level implant. And we have tried to apply this general concept on a study, on a randomized controlled trial, comparing the V3 implant and the C1 implant. We had 30 patients included, and we looked at survival and success rate of the implant, as well as the hard and soft tissue dimension. So the study is ongoing, so it's not completed, and today I just want to share some of the preliminary results. So, and I hope to give you further results later on. So this is one of our patients included in the study. So you see that she's very funny, but she has obviously an aesthetic and functional, because it's posterior, but also aesthetic in this case problem, because she's showing the first molar that is not there. And here we can see the surgery. So, I mean, in a case like this, this is a basic surgery. This is really nothing special. So we like, when it's possible, to do like a minimally invasive incision. I don't like to disturb the soft tissues around the neighboring teeth. So we can observe the drilling sequence of the V3 implant, because in this case she could benefit of the V3 implant. And what is interesting is that with all implants, whether it was V3 or C1, we could get an excellent primary stability when we're working at the posterior maxilla, because all the implants were placed in the maxilla. We have usually a type 1, type 3, or type 4 or type 3, so low bone density, and still we could get good primary stability. So the implant is placed. We place the flat side of the implant buccally, and you see here, at the time of the surgery, we placed a multi-unit. This is a multi-unit normally done for the plural restoration, but at the time we still didn't know if we would manage to do a single crown on it or not, but we decided to anyway put the multi-unit. It could serve as well for healing abutment, and it's also, you know, since we have a good primary stability, you can also tie your multi-unit, maybe not at 30 Newton, but 15 or 20 at the time of the surgery. So I think we don't have to go for all the sutures. This is how it looks after the surgery, and this is how it is after 3 to 4 months, when we were ready to start the prosthodontic rehabilitation. And on all these implants, we did actually a second study. This is a study that was performed by Vincent Delise. He's a postgraduate student in prosthodontics in the department of Professor Marc Lamy. And on these implants, we also wanted to compare the conventional with the digital workflow. So it means that for all patients, we did one conventional crown with a tight, with the Zirconia framework, and this was with the conventional impression, and a second crown that was a full Zirconia crown. We are actually looking at time, cost, fit, aesthetic, and patient-centered outcome. Here again, this is the preliminary result that I would like to share with you. For the conventional, this is the snap-on, sorry, I can come back, the snap-on component that we used. And for the optical impression, we used this scan body that is rough to improve the precision. And you can see here each patient had first the digital impression and then the conventional. I mean, I suggest that you rather focus on the digital movie here, because you all know how it goes for the conventional. impression. So first we do a first shot without the scan body, and then you place the scan body, and then you complete your digital impression. Then you can remove some of the stuff you don't want on the screen. It's very interactive. It's very nice to use. I'm not doing it myself. It's Vincent that has performed that. And then you can remove the scan body and scan the occlusion. So you also record the occlusion. And you can even check the contact point in occlusion. So for the conventional impression, of course, we reposition the replica into the impression. And considering just the two optical and conventional impression, one result that is actually preliminary result, of course, that is very interesting is we had 3 operators. 2 were senior prosthodontists, and 1, the principal investigator, was a junior. And for the juniors, it goes, the learning curve is very fast. So he was very fast with the optical impression. When the senior, they were still more rapid with the conventional way. Looking at the opinion of the patients, definitely they all love the optical impression. Well, of course, it's a little bit biased because they know that they are included in a study, but this is what we can say up to now. So after the technician, the dental technician, is working on the design of both the framework of the conventional crown and the full Zirconia framework, and then they sent the STL file to the MLAB of MIS. After a few days, we get back the Zirconia structures, and as you can see, we have a tie base, because finally we did not manage to adapt the crowns on the multi-units, and I hope there will be a possibility very soon. So we took the alternative, and of course the lab had to work on doing the cosmetic on the conventional, and for the Zirconia they did just a little makeup, little glazing. So this is our 2 samples, I would say. So we see that it's actually a good anatomy. So as Victor did, I also want to stress that this is the full responsibility of the lab to do the gluing. So in our case, we do the sandblasting, but we also protected the transgingival part because we don't want to leave some glue there, and we want to make sure that we can clean it very easily. So you see that they work with a steam device. I think this is very important to have that. Here in this case, they cemented with Relix, but I think Panavia is also recommended, is actually rather recommended. And after curing, we have to really take care of the excess. So this is how it looks in the mouth. So obviously, it fits. It's very good. In both sides, the anatomy is actually pretty good, but in terms of aesthetic, this is indeed, there is actually room for improvement. So to summarize the preliminary results, we can say that for all crowns, whether they were conventional or experimental or full digital workflow, we had an excellent fit at the region of contact. We had an accurate occlusion. It was or very good or with just little supra-occlusion, but it was similar in both groups. We had a good anatomy, limited aesthetic in the test group, but I know there is already like some development for better aesthetic materials for CAD/CAM crown. And looking at the patient-centered outcomes, already with the CAD/CAM one, the full Zirconia one, they were already happy because we were always trying that one first. But then when they were seeing the other one, they, of course, preferred. So all of the patients went back with the conventional crown because for the study and the randomized control trial, they had to have all the same type of restoration. This is here the X-ray. This is actually here the X-ray of the old study. This is preliminary, so this doesn't make sense as this step. But this is how the patient is now, and she's happy to smile again. She was actually very happy to be in the V3 group. And this brings us to the conclusion of my talk. I think that according to these preliminary results of these two studies, we have to be very cautious of the result. We can say that V3 implants do work in the posterior region. It allows a good primary stability, a good osseointegration, and I'm really looking forward for the one-year results. Looking at the full digital workflow, it sounds actually very promising. If we're looking at the accuracy, the fit, the patient satisfaction, it is actually great. It's just a little bit of improvement for the aesthetic aspect. And still for screw retain option, I think it's very good to do screw retain in posterior, but I think we still have to think. I would rather recommend actually to use a tissue level implant or a single based unit.
It's not a duo.
Sorry, it's not a duo.
No,
so yeah, but thank you. So we can close the lecture together, and I would like to, of course, thank my team for all this work, and I thank you all for your attention. Thank you.